all these really excellent efforts, organizing all these serial webinars to the ARCHI members and also other involved persons from the immunogenetics and histocompatibility. And allow me also to welcome Dr. Rabab Al-Attas, who will make this presentation with the title Challenging HLA Antibody Cases. Dr. Rabab Al-Attas is the clinical director of the Histocompatibility and Immunogenetics, and at the same time, the head of Immunology lab at King Fahd Special Dammam in Saudi Arabia. Dr. Rabab is an experienced and certified consultant for clinical pathology, immunology, and immunogenetics. She has actively contributed to advancing histocompatibility practice in the eastern region of Saudi Arabia. Dr. Attas is a member of numerous transplant immunology-related societies and has participated in many transplant-related conferences across the Middle East, Europe, and even worldwide. So, Dr. Rabab, I leave the field for you. And after your presentation, the audience and the members allow to write questions, or if needed, even to speak questions. Both are allowed. So the time for the presentation will be exactly 40 minutes. So please, Dr. Rabab, your talk. Dr. Rabab? Dr. Rabab, can you hear?
Hello?
Yes.
Yeah. Thank you very much, Dr. Ashraf, for nice introduction, and thank you, the ARCHI organizer. As you can see, good morning for good afternoon and good morning for different time zone, and we'll start immediately because I have an interactive sessions of many cases, so I might take more than the expected time, but I'll try my best to select the most important one. This is the title, and in fact, Dr. Jawdat, when she contacted me to invite me to present, I told her I thought COVID is the one now most requested by the people, and I told her, give me time doing my research and at least let me get preliminary results. But she told me, Rabab, we are super saturated with COVID, so back to HLA. Okay, so I went to the survey that she sent to me, and I looked at the topic that selected by the people, and so I wanted to make something which is new or unique, not a formal lecture, but rather than an interactive session. I'm gonna present real cases that we went through them in our lab, and it took a lot of time for us to investigate it because they are really interesting, they are challenging, and the investigation that we went through them is really deserve to be shared by our colleagues, which we learn from it a lot. And also I'm interested to hear the feedback from other expertise, how they can resolve these interesting cases. So we'll start, before I'm gonna show you these cases, let me, because I know some of the people are not from the HLA lab, let me put all of you in the same page. So I'll just take in a couple of slides about the HLA antibodies. As you know, are key factors that limit patient access to transplantation, and there are compelling evidence of the association of the acute or chronic antibody-mediated rejection with the HLA antibodies. So detection of them by the lab is very important, essential steps in order to proceed with transplantation, and actually the development of innovative assay with the use of single antigen bead resulted in more accurate and specific antibody. So now, by using this solid phase, we are capable of detecting something which were impossible to detect them due to low expression like the CW, DQ, and DP. Not only that, but it is now, we can precisely identify the antibodies even in highly sensitized patients. So actually, we can say that the solid phase assay has revolutionized the management of patient on transplantation. In brief, What's the difference between the new solid phase assay, which is in your right hand, and the cell-based assay, which we used to do in the 70s and 80s? I'm sure all people like me have gone through this.
Sorry, Dr. Rabab, for interruption. Can you move the slide? We don't see your slides moving.
You can see them moving.
No.
Are they moving now? Are they moving now?
No.
Okay. Are they moving now?
No. I think.
How can we move it? The slide is not sharing, but it's not moving. It's sitting. This one has to be closed, I think. How we can close this? Are they moving now?
No, we are seeing only the first slide.
Oh, really? Display, show. Oh, it's basically a swap present viewer. Swap. Oh. Hi. Start video. هنا okay. كمان شايف full screen.
Yes. Okay.
You can see now?
Yes, now. Can you correct the mood, please?
Okay, sure.
Okay. Make it slideshow, please.
Is it now clear?
Exactly. Go ahead. It's yours.
Okay. So this slide showed the evolution of the antibody testing. On your right hand, you can see these are the solid phase assays, and on the left hand is the cell-based assay, which we used traditionally in the 60s and 80s. And by the what we mean by cell, that you take the cells or the lymphocyte as target for the antigens, and you add patient serum, then you add complement, then you detect the death of the cells by staining them. So that this was crude, very much subjective, very much liable to this complement, despite all the improvement, like we added the HG and washing, but still remain to be insensitive to detect the antibodies. Now, in the late 80s, people thought of why not to extract these antigens, purified and label them or put them in a plates, so the ELISA plates in the wells, and detect them like any other immunoassays, which has lasted only for just a few years before it has been superseded by the multiplex, which is the more robust technique where the beads, where there are beads that are coated with purified antigens. And you can see here, you usually test 100 number of beads that coated with different antigen, and you detect the patient antibody through later. So it is very much specific because you detect only HLA antibodies. It is very sensitive since you're not seeing it with your eyes. So it gives us a lot of advantages. And in that type of beads or multiplex, we have three kinds of beads. We have the screening, we have the phenotype, and the single. Screening beads, we use it just to say the patient has antibodies or doesn't have. So positive, negative, where the bead is coated with pool of like 3 to 5 individuals. So it has multiple kind of multiple A's, multiple B's, multiple C, and etc. We have class 1, class 2. The phenotype beads coated with single individual haplotype. So you have only 2A, 2B, and 2C, which give you a little higher level of resolution. And the single bead, you just coated with single antigen to identify precisely the specificity. So as you go down, you are very much increasing sensitivity. However, these two kind of beads are native and natural, but with this one, it is manufactured, and this is the problem that created by the single antigen beads. Regarding the reading platform, you can read this solid phase assay through the conventional flow cytometry or through the Luminix. I'm sure everyone had this in his lab. And the readout will look like this for the flow cytometry. So you set a cutoff point and you see the shift of the bead. If they are positive, like this is the class 1, class 2, they are shifted, then it is positive. And if it's not positive, it's shifted, then they are negative. In the Luminix, I'm sure everyone is aware of this shape where you set arbitrary cutoff point based on the agreement with the transplant. And you can detect the positivity based on the kind of bead. Now, with the introduction of this, people thought that now we reach the ideal situation. We can correctly identify the antibody, identify the donor-specific antibody, accurately predict the cross-match, which is the concept of virtual cross-match came from, and explain it is this true positivity. For example, we used to have with the cell-based assay, sometimes cross-match and no antibodies, but now we can attribute it to the present or absent of antibody. And hence the immunological risk assessment was very accurate. Not only that, but even post-transplantation, we can follow up this patient who developed de novo or recurrence of the antibodies by monitoring the titer of this antibody and effectiveness of therapy. So people thought at the beginning, a decade or more, that now everything is solved, all this problem with the cellular-based assay have been solved. But unfortunately, as the people get more experience with these techniques, a lot of people started to talk about their disadvantages and limitation of this technique despite its power and very much specificity. Still, it has limitation, and every person who uses this technique should be aware of this limitation if he wants to appropriately interpret the results. One of the papers that came and summarizes all of this is by Dr. Gable and Bray. And it was in 2014, I talked about it, what we expected was too great rather than the expectation was great. Just to summarize for you and make it very easy, the limitation basically can give you false positive result or can give you false negative, simply as it is. Why false positive result? Because I told you in the single antigen bead, you created an antigens, which during the process of creation and coding might expose some cryptic antigens that are not existing. So what you are existing is false antibodies. On the other hand, false negative results can occur. Yes, can occur. This is a reaction, and this is subject to prosome phenomena where you have an excess of antibodies and subject to bead saturation. Another important factor, because you are introducing the serum of the patient to react with the bead. So you don't know what is going on with the serum. You might have inherent problem, particularly the complement, or the patient is on treatment, particularly this kind of treatment where you have a monoclonal antibodies and the secondary antibodies is anti-human. So these interfering factors actually can lead to either false positive or false negative result. By this, I'll start my cases, and what I'd like from you, just if you think of a solution, I give you less than 20 seconds to just try it, what you think of, okay? So again, I divided my cases into cases where you have a positive, strong donor-specific antibody, but your cross-match is negative. The first case, we have a 60-year-old female. Her son is the potential donor. And these are the typing. Of course, you expect she will be haplo with her son, but they were good in terms of match because there are only one mismatch, residual red. The DSA was an MFI of 3,400. The flow cross match was negative for both T and B, and these are the cutoff points. So, what do you think? Any suggestion? I'm gonna look at the chat. Any suggestion? Any comment? So somebody told me it's the nature. You mean that the antibodies is false. Actually, somebody can accept this. It's a low titer with a negative cross-match. But for me, I wouldn't accept it. My experience that A2, even at 2,000 can give you cross-match positive. Furthermore, you're talking here about son to, you have to take everything. Son to mother, which potentially exposed to the father, and she has paternal sensitization. You have to be sure this is not a true antibodies. Now, if it is denatured, then what is the solution? What to do in order to resolve this? Is a false antibody and due to denaturing. Anybody can suggest? True, son to mother is high risk. You have to rule it. Excellent. I don't know who said, but anyway, I'm not gonna mention names. So everyone can write whatever he wants. You do acid treatment. Acid treatment, you know, the antigens of the class 1 consists of alpha and beta chains, isn't it? So a true antibodies have this structure. A false antibody usually have only the alpha chain. And if you wanted to treat this with acid, it will dissociate this combination. And a true antibody will disappear like this. This is a positive control. Always when you do acid treatment, you run a positive control of highly sensitized patient. And after treatment, these antibodies, because they are true, completely disappear, as you can see from this picture. Now let's see our patient. You remember it was about 3,000, and after acid treatment, you can see the T shoot to 20,000 between 15. So this is a truly false antibodies that you might ignore it, despite it is a risk, because, but my experience, this ladies above 60, they start to lose their antibody. So excellent for those who suggested this. Now, another technique that you might have to do if you don't have the protocol of acid treatment, it just always have an alternative way. We said it's always nice to have a source of antibodies or antigen that is natural. We know the solid antigen is manufactures HLA antigen. The flow BRA, on the other hand, has different readout. It deals with natural antibodies. So if you have facilities to have this, you can do. And let's see the shift. This is a class 1, this class 2, and there is completely lack of shifting, meaning thereby it's a negative and there is no A2. It was just false positive result. Okay, clear? Shall I move forward? Okay, let's go to case number 2 then. He is a 60-year-old male, has no sensitization history. Important always to have a sensitization history, if possible, from the coordinator. And this is the typing of the donor and the patients. Okay, as you can see, there is the mismatch is highlighted in red. So we have A, B, C, single mismatch, 2 mismatches, and DR. So they are not good match, but anyway, he is the only available donor. And among these mismatches, we have DQ7, 8 and 9 in the range of 6 to 8,000. Remember, the donor is DQ7. So we did the cross match. The result is clear negative for class 2, and again, negative based on our cutoff points. So what do you think? Please let me know how you think of it. Is it okay? Is it okay to accept this? This is in the range of 7,000 with clear negative B-cell cross-match. As you know, class 2 will cause only B-cell cross-match. So what is the possibilities? Any suggestion? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Check the alpha. Let's see, check the alpha. Okay, not bad. Let's check the alpha. But these are, so usually if it is DQ, you look thoroughly to these antibodies and just identify them. So these are the patients who has all the DQ7 are almost positive with all the alpha chain. So there is DQ7 antibody, whether due to alpha or the beta. The problem here is the cross match here is negative despite of this strength. So we need to know if this is a true antibody or not. This is a class 2. Remember, I said in class 1 you might do acid treatment. In class 2, maybe not useful, this technique. Where did the antibody come from? We don't have all the time history of sensitizations, but this is very important. We have to know the history of sensitization. If this patient doesn't have, and this is the first thing you have to do, never been exposed to sensitization, true, you have to question these antibodies, but furthermore, to confirm you're suspicious is to do what I have mentioned. If you have another technique, just write. What is this on the right hand? What we call this? This is a single antigen bead, and this is a phenotype bead where you use, you remember I told you there are 3 kinds of bead: the single antigen, the phenotype beads, and the screening bead. The phenotype beads is kind of natural or native. The titer is shown there. It's about 9,000. And you can see it is clearly negative. So when you have more than one assays and they are not consistent, always questions, because a strong, a genuine, a true antibody usually will give you positivity in all kinds of platforms, okay? But when you have inconsistency, then one of them at least wrong, either this one or this one. Now, added to this, we have to do, as I said, flow BRA. I like it because just from the looking at the shift, you can tell. So you have 3 kind of tests, 2 of them negative and 1 is positive. So there is inconsistency. It's likely this result is negative. You may do, somebody told me you may do cross-match with another 2 surrogate cells to prove that the cross-match is negative. But we were satisfied with this finding. By the way, DQ7 and 8 and 9 is not uncommonly, maybe some of the attendants can tell me about his experience, not common to have a negative result. This is a patient who have, in fact, he's a child, he has a strong DSA, CW17 of 14,000. His mom is the potential donor, and in children, you have to be very accurate as much as you cannot give a child, he's just young, a transplant of high risk from his beginning of his life, because this patient is likely to live with it and to have a second transplant, third. So start with a very clear risk. This is a patient who came with 14,000. The cross-match was negative. And he is from his mother. So, any suggestion? To look at the CW17, this is the only antibodies. Just for the sake of time, I'm going to tell you, first of all, these children, they are the 3 things that you have to question. It is a retransplantation, blood transfusion, as well as multiparas. Usually children do not expose to these things. So no history of sensitization. This is number 1. Now this is a class 1 and we can do as a treatment, isn't it? Unfortunately it didn't work. This is what I'm gonna stress on it. Not every time your protocol work with every patient. Why? I don't know. We need to investigate this. So what is the next step that I can do to help this? I have to tell them this is because pediatrician will not take the risk of transplanting this patient until you tell them, oh, this is a false positive. So I looked at the screening. You remember our protocol, we do screening and then we do the next step, single antigen. The screening is clearly negative, but the single antigen is positive. Furthermore, when I did the flow BRA, it is clearly negative. Okay, so back to the inconsistencies of the results is usually mean that a result is wrong or false, your initial single antigen. So this patient has been transplanted and we told them confidently CW17 is false positive. Now, what the 3 cases teaches us is the antibodies against denatured epitopes, and this is one of the early limitations that has been reported. And as I told you, because during coating, you change the native conformation, so you might express cryptic epitope, resulting in antibody even in non-sensitized male, and one of the early papers appeared in 2008 by Dr. Morales and his colleagues and Alawar. Not only that, but even recently, not so much recently, class 2 antibodies, false antibody has been also reported. So take care of these antibodies, take care of the history, and there are fun publications. I'm gonna show you the list of them. What is the clinical significance is questionable, but very likely they are not important, and they, in one of the papers, they might be as high as 40%. And the problem of this, if you rely on them, they can lead to miscalculation of the calculated and false allocation. Plus, it always gives you inconsistent result in the cross-match. Okay, how to treat them? I told you these are the possible treatment, and these are the list by 2 authors of the commonly found denatured antibodies. As you can see, not all of them rare, but some of them is actually very much prevalent in the population. So have this list like what I'm doing in your office, and I'm now working on growing our own list to see. Now, if you come to the CCW17 is one of the top prevalent, frequent antibody that is found in healthy blood donor without even sensitization. Now, before going to the opposite scenario where you do not have antibodies, but you have strong cross-match, I just want to show you two interesting cases because I cannot classify them as true because they are true or false because they are also false. Anyway, let's see this case, and those who came across this publication by us might understand this. So this is a 23. Am I fast, yeah, Fadi? Or it's acceptable?
You are in time.
Okay. So this is a 23-year-old male. Came with living related donor evaluation, and this is his antibody. He has, again, DQ7, 8, and 9, okay? 3 donors were ready to donate for him. One of them is his sister and 2 cousins. The 2 cousins are brothers, and these are the typing. The patient has class 2 only antibodies, and as you can see, 7 and 8 and 9, DQ7 and 8 and 9. So the first donor, his sister, she has both of these antigen. The second donor is homozygous to DQ8, and the third one, he has DQ8. Now, what do you expect the cross-match? What do you expect the cross-match for them? Of course, you expect positive. It comes that donor 1 and donor 2 positive for B, and that the mean channel is 170 for the first or the sister and 223. Strong cross-match, which is okay. This is very much compatible. When we come to D3 or the donor 3 or the second cousin, it is negative. We repeated this cross-match maybe 5 times with 4 or 5 technologies. Every time give us. So we get happy. Now, we wanted to give him one of this kidney, but still we were worried about this. Why is not reacting with this donor? So what is next? For the DQ antibody, somebody suggested, if you see the DQ antibodies and the antibodies doesn't give you, you look for the, any suggestion? The alpha chain, excellent. So you go with the alpha chain. That is what we did. So these are the DQ8 and 2 positive and 1 in the negative sign. So I said, oh yes, then it must be due to alpha chain. This is O2 and the rest is O3 alpha chain. So what is next? You look at these 2 donors. But unfortunately, when we did the donors, actually nobody have the O2. Everyone has the, this is the DQ8. This is the DQ8, the second donor homozygous, and this is the DQ8. All of them, they have O32. You don't do high resolution typing for the Q. At least we don't do it at that time, but by the association, you can predict. So it's either O32 or O31. And the cousin is not the one that is negative. He is O31, which could be a possibility. So it didn't solve the problem. In fact, we at the beginning, I was happy. Oh, maybe it is the O32 that is causing the problem. And then the reviewer told me O31 and O32 alpha are the same. They are the same. So I thought maybe it is the unique combination of O32 with the DQ8 that created the problem. The patient doesn't have antibody. What I'm showing to you, it just doesn't have DB antibody. For those who commented, that you can see the DB is completely negative. So the only antibody is DQ7, 8, and 9. So it was really a dilemma. We cannot attribute it to 8. We cannot attribute it solely to alpha. How to prove that this combination is the cause? So what we did a surrogate cell, which is very cheap things to do. And we choose 3 kinds of surrogate cell. One is having DQ7 and 8. One have homozygous DQ8, and one but with the DQ alpha O32, and another one with O301 alpha. And this is just to summarize the results. So the first surrogate cells is very more or less the same as the second donor, homozygous DQ8, and he has a strong channel shift. The second donor is like the sister, who is, the third donor is like the sister, 7 but without it, and to our surprise, it came negative. So actually DQ7 has nothing to do. And we brought another donor who is just homozygous to DQ8, and it came also as positive. So we thought that then DQ7 is nothing, and possibly this explained the lower channel shift with his sister, because we assumed she has 2 DSA, but she gave lower. And we came to the conclusion that it is the O3-2 in combination with the 8 that give the positive result. Luckily enough, at that time, we have this specificity flow PRA, and interestingly, we found the only bead that is shifted to the right is carrying 8 with a homozygosity to O3-O2. This one is present in the sister, 1 copy, and his cousin, 2 copies, but is not existing in the brother. So, or the brother of the first cousin. And we now confidently tell them this patient doesn't have a DSA, go ahead and transplant him. But really it took like 6 months to reach this conclusion. And now he's enjoying his transplant. One more case, just an easy case, forward. I do not need to tell you the history. Look at this. This patient came to us and this is the result. From the first, at a glance, what is the problem of this single antigen bead? Quickly, it's easy. Those who are doing single antigen bead can, exactly. Pan DR. The patient is reacting with every DR, even his own DR, which is 8 and 11. So once you see this, this is then false of the nature or whatever, because he is reacting as for his own antigen. And furthermore, if you do phenotype, it will tell you. So please, before you interpret anything, check the self and to check the DSA before to proceed with the interpretation. Okay. Excellent. To answer, it is a pan-DR. You can do pheno, and this is what we did. Thank you very much. Now we go to the opposite scenario, which you have negative DSA or even weak that cannot explain the strong positive cross-match. But of course, this scenario is very much consequential and more important, because the first scenarios, at its worst scenario, you're gonna deny transplantation unjustifiably, okay? But with this one, unless you recognize the case, you might transplant someone who is sensitized, and then you can elicit a memory response strong that lead to rejection, as we will see in the coming cases. Okay, ready to go to the second scenario? Thank you very much. Somebody told me excellent case. I'm thanking him. Okay, let's go to the scenarios, and I have 4 cases if time allows. This is a young lady multiparous. Once you see a young multiparous, khalas, stop at here. She must have paternal sensitization. And always the son or the daughter will be the potential donor. She's, as you can see, positive for class 1 and class 2. I'm gonna show you class 2. But of course, this is her son, so he's haploidentical with single mismatch at each locus. Among this, it's the A3 about 2,000, and the DQ2 here is about 3,000. So, and they are just barely positive. So this is her A3. Just on the cutoff point was 2-3. But look at the cross match. She has a strong T cross match and a strong B cross match. So, any suggestion? What's the problem, first of all? Again, this is the DQ2. Okay, and many of the DQ2 in fact negative. So if I assume this is DQ2, it's just less than 2,000. And despite of this, you can see how strong. So what is the problem? Prozone effect, excellent. So we thought this might be a prozone effect. And actually the A3 is underestimated. So this is the problem. She has a weak or just moderate weak DSA, but she has a strong. When you think, just think systematically. So either this is wrong or this. The cross match is always, you have to believe in it. You just repeat it, refine it. If it's positive, positive. The problem is with the antibodies, because we mentioned there is a lot of limitations, plus the skill of interpretation. So what's wrong? Cross match is not consistent with DSA. Let's agree about this. What to do next? Somebody told me Brozone. Excellent. We did Brozone. This is the need, which is 2,000. And look at 1 in 10, completely disappear. So no Brozone. Think. Another. What to do? Any suggestion? No suggestion? Okay. Let me show you. This is the A3. When I look at this antibody, still no suggestion. Okay. When I look at, and let me tell you how I deal with this, and you let me know how you deal with it. When I look at antibodies which is weak and creating a strong cross-match, usually I look the top to the top one and see what is the relation between the top one and our DSA. That's my approach. Here, the top one is A1 and it is 15,000. Why I do this? Because, no, it's nothing to do with allele, because here it is one bead, A3 was positive. There is no more alleles and the patient. So somebody check the Craig, excellent. So this is part what I'm saying. Look at the DSA and look to the top one and the series after the top one. We know that A1 and A3 are belonging to Craig number 1. Craig number 1, oh, A1 Craig, and everyone, I believe, I've gone through this old book, Beyond Tear, and this is one of the first group of cross-reactive group where you find all this A1, 36, A3, 11, 23, which are exactly here, A23, 24, 36, 11. This group of antigens, they share some kind of polymorphism that we call it public epitope. So if the antibody is reactive with this shared epitope, you can imagine it reacts with all of these beads. So they created kind of delusional effect. And what you see is just underestimated. And when you cross-match with this patient, cells, you will definitely have them positive, or at least is not consistent with the titer of the, or the MFI of the DSA. So remember always in this scenario, the correct group, and always have in your office, like what I'm doing, just hang this, and whenever you get the antibodies, look at these. These are the common correct in the A and B group, but they are not the only one. We know we have DR Craig, we have CW Craig, we have DP Craig. So always remember this. When you have a cross-match positive or strong positive, not explained by an antibody which is weak. Okay, next. If I am fast, please, Dr. Ashraf Dada, let me to stop, or at least to break. Okay, that's.
You have still 10 minutes.
You have still 10 minutes. Okay, this is second case, 35 years SLE patient. And the patient is a second for retransplant. She has only weak reactivity to DR17. However, the cross-match is strong B positive, which is 147, which is not explained. Weak reactivity meaning less than even the 1,000. So how do you think how to solve the problem? Okay, any suggestions? Or what to do? But all of these patients, when you have a strong cross-match positive, the first thing is to do is what? Please help me. Is to do auto. Do auto cross-match, because maybe it's auto. Particularly this patient is an SLE. Yes, excellent. Somebody told me auto. It is excellent, but unfortunately it came negative despite an NA of 640. So it's not always the way you think. Again, we said about Brozone phenomena, which should be, and this is the 17, which is very weak, with dilution disappeared completely. So there is no questions of Brozone phenomena. So we have to know why this is strong cross-match with this weekend. Look again back thoroughly and look to the phenotype of the patients and the donor. This is the patient who is DR7 homozygous, and you give him a donor who is DR17 homozygous. You know, DR17 is associated with DR53, while DR17 is associated with 52. When a patient is homozygous, he's very likely to respond to, because he doesn't have, he's not exposed to the 52 or 53 or 51. So you add to him a donor who have double the dose of 52, it's very likely that he gonna react strongly. And this 52 is considered to be public epitope. So the combination of 52 plus the weak reactivity, all of them has contributed to this. And the clue to this is homozygosity of the patient. So please look at the phenotype. Case 9 is more or less the same, where here we have DR13 in a patient who is homozygous and DR52 is a cross match of 146. So it is more or less the same, and we treat it exactly the same. But here we have a flow array added, which showed clearly there is a positive class 2. So you don't have to play with this because it might react strongly after that. Okay. In this case, you have to look at, you know, the DR 11, 12, 13, 14, 18, 17, all are associated with 52. What about the 8? It is found that the 8 is commonly cross-react with this. I'm sure everyone know that DR 51 associated with 15 and 16, 53 with 4, 7, and 9. But 52 exactly, I mean, particularly, they are, DR8 is cross-reacting with them, although you might not have any association. And this pattern, you will find it very commonly. When you have this link, you have 8 on top. So we come to the probably the 4 plus the, this is a patient, no, sorry. A case number 9. No, I already, what I'm doing. Okay. طبعا this is further to confirm our presumption, and we did surrogate cell, which confirmed the positivity. Case number 10. She is a patient, this is her typing, okay? And she has only moderate DSA, which is about 4,000. Despite of this, she has a strong T and strong B. So what is next to do? Most of this, how can it code this positive cross-match? Question about previous case. Okay, can I answer later because I have to proceed, but I'm gonna answer your questions. Just keep on asking it. So what is wrong with this patient? What is wrong with this patient? Any suggestion? Is it wrong cross-match or wrong DSA? Always think in that line. Cross-match wrong, you have to repeat it. It is clear, it is a strong cross-match with weak DSA or moderately weak DSA. Look at this is the DSA. Let me show you one tool to learn. I'm not sure whether I can have it, but anyway, you see this thread or a string. Okay, it tells you always these antigen are sharing some, and you can see them in the 5 Craig or 12 Craig. But let me see if I can just do and show you some tool. Okay, now this is a patient. Okay, you see, if you look at the the Fusion software, but I'm sure in Luminix there is something, and you take all this thread by moving. Okay, let's see here. I don't want to show you. And you move this one and take all the thread till the end of the positivity and click here. Let me show you something in epitope. And look one by one for those common string that is present, which is the 44, press for simplicity, 44 and 71, all this is thread that I presented to you. It will tell you that this have common, which is 69T applet. So this is one of the tools that you have to be aware of it. Let's go back to our presentation. Okay. Okay. So this is one of the tools that you may utilize if you are thinking of Craig group, and this Fusion or whatever epitope is also existing, and these are all the threads that I told you. You can detect it by HLA matchmaker, epitope, but this is very helpful to tell you what is the common or public epitope. epitope, and actually it has been mentioned by Dr. Duquesne, the 6090 NT residue, which is shared by all of these threads, which actually a patient positive for all of them. So what happened in these three cases? This is another flow array to confirm. What is this? Anybody know what is this? What is this test? What is this test? It's a flow DSA. We were actually validating the flow DSA, which is a kind of test that combines the detection of antibody. Somebody can mute because I'm hearing some noise. Okay, so it's proved to be positive for class 1. So actually you have an antibody that is strongly causing a cross-match by all the available technique. You cannot ignore this antibody despite it was 4,000, and you have to take it as high risk. The last case is easy and somebody answered the question. Look at this one again. This is a weak antibodies, but he has this cross-match result. I don't know, somebody will tell me, okay, what's the problem? It's weak and weak. And for me, I don't like this borderline. And I want it black and white. Negative, cross-match, negative, clear. If something there, you have to investigate it further. And these are the DSA. Any clue? Somebody answered before this case. BW6 and B, that's true. Okay, so these are the pattern that we look. How do you know this is a B6 correct? Let me give you a clue. If the donor is homozygous for BW6 and the patient is homozygous for DW, it's very likely that he gets sensitized. The opposite is true, because the patient is not exposed to this DW6 and you give him a double dose, which is diluted among all of these three. Very unlikely that you have the DSA at higher MFI, but despite of this, the cross-match will be positive. So you have to list as an unacceptable all of these when you choose the donor. Surrogate cells was also confirming. In all the previous cases, I was talking about something called shared epitopes. When the antibodies react with the antigen, doesn't react to it as lump and sum or one piece. Actually, all the antigens or HLA antigen consist of many polymorphic residues, or we call them epitope. Some of these epitopes can be shared in more than one antigen. Like here, for example, you have 4 antigens. This purple diamond is shared by 3 of these antigens. So if the antibodies is not, and some of them is private, like, and this is a private antigen. So if it is private, then you will find it corresponding to the MFI. But when the antibody reacts to something which is shared, we call it public, then you can expect that this antibody will not give you higher MFI or get diluted, and this is what we call it spread too thin, or why it's not moving, cancer. A spread too thin, or the peanut butter effect. Always remember this can occur with the public epitope 52, 53, BW6, BW4. So always remember that the MFI here is not accurate and it is underestimated due to dilution, and it is not surprisingly you get a cross match, doesn't match with the power or the strength of the antibodies. Okay, this is a patient who came with only DQ5 for third transplantation. This is an unfortunate patient actually. And this is the pattern of his antibodies. There is no DSA in class 1. And these are the only DSA. We get happy because if you find a highly sensitized patient and you have only a week, you should always try not to lose this donor. This patient has DQ5 DSA. What is this? Okay, so we find 2, 5, one in the positive, one in the next. You check the DNA in this case, and we were so happy. Okay, the donor is this one. We check the, what we call it. It's not moving, huh? Okay. So we thought these are 2 kinds of bead. DQ501 is positive and DQ502 is negative. When we check the donor, he was DQ502. So we get happy. This is the patient who has negative DSA, and the cross-match was negative. So we release him as a standard immunological risk. What happened? In 2 weeks later, the patient came with rising creatinine, typical antibody-mediated rejection with C4D positive. So the question, what we did wrong? I was very much upset of this patient. This was the antibody pattern immediately in 2 weeks, where the first DQ come to 15 or 18,000 and the second DQ come to 6,000. Okay, so what is the problem of this and why, how we miss it? I came back and look at the alignment. Of course, you can do alignment routine as well as the bases. It came that 0501 and 0502 are the same. So actually the patient started with a DSA of about like 3,000 or 4,000. So it was not negative. But this doesn't explain this strong reaction. Am I all right? So what do you think? What we did wrong and well, how to learn from this case in order to avoid, because this patient almost lost his kidney. Okay, somebody will tell me Prozone, because I have to go fast. Maybe we missed it because it was, so we treat all our sample with DDT, and I did 1 in 4 dilution, and the DQ5 disappeared. So there was not a Prozone phenomena. It was really weak. I had to do surrogate cross-match with the post-transplant and pre-transplant, and I choose exactly the same phenotype of the surrogate, which is DQ506. I look at the pre-transplant, he was positive in the pre-transplant and even stronger in the post-transplant. Although our cross-match was negative, I didn't recall. So as I said, we were evaluating the flow DSA. So I enrolled this sample with the evaluation and I cross-match, and it came to be positive. Actually, so the patient has cross-match positive due to DQ antibodies. How we miss? What is the problem of this patient? But this patient, when we came to us, we don't know that he is a third transplant. This is very important. Nobody mentioned to us he is a third transplant. You never release a third transplant or a secondary transplant as a standard risk. This is the first mistake. The second thing, always I write this statement. The pair demonstrate patient historical serum demonstrated negative DSA, SAB on the serum, the current one should correlate better. But I never recognize, although I am the one who put it, its significance. Actually, these patients who are kept in the list, we do every 3 or 6 months their DSA. But when it comes to cross-match, we take the latest, which might not have a DSA. So what happened that we were misled. First of all, nobody told us this is a retransplant. Second, we misled by the negative result, which was not the serum that we cross-match with might have some positivity. Thirdly, possibly our cross-match was not sensitive to detect a mild positivity. So this is the lesson you have to learn from these cases, which is very important. A new sensitization event. This is a child who had many potential donors, and always he consistently with his family.
Dr. Rabab, we should come to the end.
Okay, so we'll go to conclusion. Okay, I'll come to conclusion, and then. So this is the definition why Prozone effect came, but take home messages from all the previous cases. First of all, never release discrepant result. Please, please, please don't release discrepant result between the DSA. Always investigate and consider sensitization history, which are the 3 important one in this one. Pay attention to the CRIC and include all the CRIC specificity as unacceptable. Pay attention to interfering factor by doing dilution. And in the next slide, I showed some of the solution, but maybe we can include it in the questions sessions. Pay attention to the denatured antibody, have the list, as I said, always surrogate. This is a very cheap approach. Everyone can do it without any other template, but you can learn a lot from this. You have to know that you cannot ever assign exclusively based on a single antigen without doing other alternative approach. use all the epitope analysis like HLA matchmaker, IMVT alignment, Craig chart, epitope. There is something called epitope registry, which I don't know a lot. Many things in it. I'm just learning, but practice it till you learn it. But I'm happy with the epitope analysis software. Always multiple approach is the best to provide you most of the complete data. And you have to understand the limitation of the antibody assays. You might need to do high resolution, some time to resolve the problem. Pay attention to the homozygosity of BW4. And in the DQ and DB, always check for alpha and beta combination. We have included all of these things in this paper, which we published, and we found the flow PRA is very useful to resolve many of these issues, easy to interpret. I advise the younger HLA technologists to have their checklist for antibody. Like always, when you have an antibody, before doing anything, just go through this. Check the controls, check if there is self-antigen to exclude, do current agree with the previous historic, do whatever, do all assay platform agree, if there is evidence of prozone, if there is discordant results with the cross-match, and then you can order your test. And we work on an algorithm, which I'm still validating it, so the thing becomes smooth and people can go with it without my need. So these complicated cases actually represent 5 and 10% of our experience. However, it took more than 80% of our time. But the beauty in this, they provide us with new knowledge, okay? One more important factor that we cannot control, even if you do everything, the biology of the immune response, nobody can predict it. So I'd like to thank my people who did a lot of things that you can, appreciate from all of this. Most of the investigation and were done by their help and assistance, Sabir, Kenana, Amal, Mariam, and Shaima. But a special thank to these people, Mr. Ricardo, who thoroughly left us with our flow man. I learned a lot from him. And the promising flow woman, his student Zuhur, who did a lot of investigation in order to resolve. They were doing this happily and never feel compromised. Thank you very much for listening and ready to hear questions.
Thank you very much, Dr. Rabab, for this interesting and exciting presentation, presenting many aspects like the nature antibody, false positive, single antigen, test screening, test prozone effects or gate cross-match, cross-reactive groups, shared epitopes, auto cross-match, and all others. So I think we have now about 10 minutes for questions. Either you can write it or you can also speak it. Please. Raise the hand, then I can see and they can make you unmute. So any questions, please? Any questions? We have, I think, here one question. No, this is just comment. So please raise the hand if you have any question.
Seeing that everything is clear, Dr. Ashraf.
It seems to be this clear. It is very, very interesting. Actually.
Or completely unclear.
No, I think it is very clear. So high quality technical aspects, very good presentation. So if we don't have questions, maybe I can ask you, Dr. Rabab,
sure.
How you, what's the first clue for you to explain the prozone effect, especially by using one lumbar system? We observe this frequently. What's the first clue for you to not to overlook such phenomena?
What is my clue to predict prozone phenomena?
Yes, yes.
Okay, first of all, in the clue that the patient has weak antibodies and strong cross-match. This is the first thing that tell me it is you have to exclude prozone phenomena. You have a weak antibodies, but despite of this, there is a strong cross-match. Then I go to the investigation of this. I make dilution and see how the pattern. If the antibody gets higher, then this is definitely a Prozone phenomena. But most of the time, to tell you, dilution rarely reveal Prozone. From my experience, dilution due to this figure, which you can see here, I'm not sure whether you can see, the Prozone that we talk about, where you have an antibody excess, so the antibody compete with the antigen until you dilute it to reach a zone equivalence to show. This is not the commonest one. However, we have discovered Prozone. What is common and what we have shown is that there are interfering factor or blocking, and it has been published before. It is the complement. And that's why one of the cases that I went very fast in this patient is actually interfering or some factor that prevent the combination of the serum with the antigen, giving you a false negative antibody or weak antibody. So you have to treat. One of the methods is to do heat activation. You have to try everything. Heat inactivation sometimes works, sometimes doesn't work. What I found really to work is to do dilution plus the DTT treatment. This is a case which was confusing for us. Always there are DR4 in a child. We did everything, but then it comes that when we did the dilution plus DTT, it resolved the. Why DTT? Because DTT, chelate the calcium and remove the complement from there. So you do everything, but first of all, you have to have the sense that it's possibly Prozone because of inconsistency between the cross-match and the antibody. These are some of the solutions: dilution, heat inactivation, EDTA, but we didn't yet validate it, as well as you have, of course, to have another technology, do flow PRA. Sometimes it might be helpful.
Yes, thank you. Any further questions? Please be motivated to ask questions. So we have still 5 minutes. So I don't see hand raised. So I ask you, nobody raised the hand. Do you recommend the regular dilution in all antibody screening tests to avoid Prozone effect? Because some people do this and they haven't observed, for example, using EDT regular for all cases.
Yeah, you are absolutely right. Some people use upfront diluted serum. Some people, they upfront use EDTA and or DDT. Now, everyone has to validate the way. For us, we have validated the DTT, and you have to validate, meaning thereby that your treatment will not affect the actual antibodies, but it can resolve some of the problem. We have validated DTT, and it works good with us. But it's still some cases like the one I showed you, you need to have further. So we combine the DTT plus the dilution. We are now in our way to validate EDTA. If you go to literature, EDTA is said to be the best because we most of the study that they have shown that the most factor that important for the Prozone phenomena is the complement. So you have to get rid of this complement by any means from the beginning. The manufacturers, so getting of the complement is either by chelating the calcium or the dilution will get rid of this, or you heat inactivate. But the manufacturer insert doesn't advise for heat inactivation. So my suggestion that you have to validate your own way, and you have to treat the serum by a way that will get rid from this Prozone phenomenon from the beginning. I think this is the best approach. You have to validate which one works better in your situation. And then you develop it as a routine.
Okay, we some as I mentioned, it is maybe recommended for large centers to avoid such difficulties and overlooking maybe and repeating the test. So there's here a question from Hanouf, Dr. Hanouf. I have a question about case 8. Please, DRR52 had low MFI value. How can it cause this positive cross-match results?
The questions written here in the chat.
Yes.
I have a question about case 8. Please, DR52 and low MFI value. How can it cause this positive cross-match? If I am not mistaken, this case has two kinds of antibodies. It has a DR plus a DR52. So it has a DR17 plus DR52. I told you the patient had DR52, which we didn't pay attention to it. Let me go through it.
Hello?
Yes. So the patient has two combinations. It has DR13 or 17 plus the DR52. Now, considering the DR52 is public epitope, meaning thereby it can be shared by many antigens, the actual 52 is underestimated. Second thing, this patient was homozygous for DR53. Always check the patient phenotype. A homozygous patient is very likely to get sensitized, If he doesn't have variability, for example, 52 and 53, he is always liable to be getting sensitized. Now, added to this, you give him a donor who is homozygous for something he never been exposed, it definitely will give you a positive reaction. So always look at the patient homozygosity plus donor homozygosity. And I found most of the cases is like this. For the DR, most of the cases is this scenarios. Donor homozygous for 52 and you give him a 53 donor. Or donor homozygous for 52 and you give him a 51 donor. So these are usually the causes because 52 and 53 and 51 are public epitope shared by many beads. So what you are detecting is underestimated. So variation is always good. The patient who having 52 and 53 is very unlikely to get sensitized to them because he already has been exposed.
Okay, thank you very much, Dr. Rabab. Our time is over, but I give opportunity for last question, if any question. Either by voice or by written question. So we haven't, then thank you all for coming and or for hearing, showing the presentation. And I want to thank again the ARCHI organization and Dr. Rabab and all the